And the general principle of this course is to try to tell you a lot about the mechanism and the physiology, because we think this is how it should work at the bedside, more than giving recipes. We will have some recipes, some guidelines, but we will try to make it based on the physiological reasoning as much as possible. And of course, based also on the experience of the speakers and people presenting today. So that's why this very first talk I'm going to give now is about really the physiological principle, the physiological basis. So, so yesterday, one of my fellow is coming today, said I may be late. I say that's very, very bad, because this is the only important talk you have to listen to. So that's bad for him. I see he's late. So and it's about the equation of motion. So I will show this slide once. I won't show it at every talk. To say that our laboratory has received equipment, sometimes some research grants for clinical research project. And we have been working with Medtronic Covidien. We have an ongoing clinical trial on PAV. We are working with General Electric for lung volume measurement and ultrasound. We are working with Philips for sleep studies, working with Fisher-Paykel on high flow therapy, and Air Liquide on helium and CPR. So that's the conflict of interest, which means we have been receiving equipment or sometimes some research grants. So this is the most important, maybe the only equation you need to know, because it tells what's the relationship between the pressure, the volume, the flow we see on the vent, and it really explains how the different modes of ventilation work, but also interact with the patient. And what you will see and understand and use in your practice, I hope, is that mechanical ventilation is an extraordinary tool to assess patients' mechanics and to do pulmonary function tests. And you will see that this is why we have made progress in critical care, because in the field of mechanical ventilation, we can assess the patient. So please, when you have a patient under mechanical ventilation, use these tools. So we are going to discuss this equation, which is based on the different forces playing a role. We are going to discuss pressure. Pressure is force, right? It's force per surface area. So when we see pressure on the ventilator, it means that there are forces which are counteracting the entry of flow and volume into the system. So we are going to discuss the two main forces, the resistive forces and the elastic forces, which are described by compliance or elastance. And we'll talk a little bit about the issue of time constant and the consequence, which may be auto-PEEP or intrinsic PEEP. Is everybody able to see the slides correctly? Is that okay? Okay. So let's take the basic mode of ventilation, which is volume control, which in fact is flow controlled really by the ventilator, because volume measurements are a little bit complicated, and what the ventilator is really controlling is the flow. So this would be a volume control or flow control breath, where you have the airway pressure, you have the flow, and so this is a bit schematic. It's a very, very square, good shape of square flow. And you see, this is what is controlled by the ventilator, because the core of the ventilator is a servo valve, which is calibrated. So when it opens to a certain degree, this, for the ventilator, means a certain flow. Okay, so a square flow means it opens to a certain diameter and closes after a certain time. Because flow over time is volume. This is how the ventilator gives volume. So what you see here is what we can observe in any patient under controlled mechanical ventilation, so a passive patient, is that the pressure is going up to a peak. And what has been added here is a small pause at the end of insufflation, which means the ventilator gives the volume and then stops, but do not open the expiratory valve. So it's like if you take a deep breath and then you stop, okay? So what's interesting here is that when you do this pause, this short inspiratory and inspiratory pause, you see that there is a drop in the pressure, in the airway pressure. So what we are going to describe is why is there a drop in airway pressure, what does it mean, and what can we do with it? So this is where we have to go to the equation of the respiratory system. This equation is a simplified equation, if you wish, but it tells at any moment of the breath what explains the pressure. So we are going to look at the peak pressure, but we could apply this equation at any time during the insufflation. And this equation says that the pressure is the sum of three components. The starting pressure, so where do we start from? So it could be zero. With zero, we say zero, but it's not zero, right? When we say zero, which pressure is it? It's the atmospheric pressure, which is not zero. So by convention, we say zero. So for instance, when we say negative pressure, it's not negative. It's just below the atmospheric pressure. So it could be zero or it could be PEEP, right? Plus some pressure which is generated by the resistive component, so the resistive forces. And resistive forces mean that there is a friction of molecules against the walls of the airways or of any tubings, conduits. It's the same in the vascular system, for instance. So it's dissipated pressure because of this friction, plus a component which is due to the elastic forces. Okay, you try to expand something which has a recoil force. Okay? So P0, okay, this is a starting pressure, plus a resistive pressure, plus an elastic pressure. So what the way it is written is the resistance of the respiratory system times flow. And if you don't know what a resistance is, how it is calculated, you know that this part of the equation should be a pressure, right? Resistance times flow equal a pressure, okay? So a pressure, it's easy to understand from this. A pressure is what? If resistance times flow is a pressure, a resistance is what?
Airway resistance and tissue resistance.
This to obtain this equation, resistance times flow equal pressure. So it means the resistance is a pressure divided by flow. Every time we speak of resistance, we speak of a pressure divided by flow. Same thing in the vascular system when we calculate vascular resistance, right? We divide by cardiac output. Here we divide by the flow rate of the insufflation. So this is the resistive pressure. And the third component, is the elastic forces. So the recoil forces, which resist to the expansion. And same reasoning, if you don't know what is an elastance, you see that elastance time volume equal pressure. So elastance is pressure divided by volume, okay? And this is where there is something a bit complicated, because we can use the term elastance, which is pressure divided by volume, or the opposite, the reverse, which is volume divided by pressure, which is compliance, okay? So it's always a bit confusing, compliance, elastance, which one is volume over pressure. So one way to remember it is to remember this equation, because elastance is like resistance. If you have more elastance, you have more pressure, okay, like resistance. Compliance, it's the opposite. If you have more compliance, you have less pressure. So this is the resistive pressure, this is the elastic pressure. So at any point in time, and this is true for any mode of ventilation, the pressure is the sum of these three components, right? Okay, so I've shown you this drop in pressure when we do an N-inspiratory pause. So regarding this equation, what do we do when we make a pause at N insufflation? We stop the flow. So let's say if we accept that we make the pause almost instantaneously, okay? At the peak pressure, we have the three components of the equation. And just after the pause, we have only two components because we remove the flow. So that's what you do when you do an N-inspiratory pause. This is a pulmonary function test, really. So the peak pressure is the sum of the three. When you do the pause, you remove the resistive pressure. So what's left is the elastic pressure above the starting pressure. Okay? All right. So this is very important and interesting to know. First, because it gives you directly in front of you the mechanics of the system, what is the contribution of the resistive pressure, of the elastic pressure. But also because it tells you exactly what is the pressure beyond the resistance. And remember, resistance, it's dissipation of energy due to the friction of the molecules. So after the resistance, if you wish, this pressure is dissipated, has disappeared. So all the resistive pressure you see does not exist in the alveoli. Okay? This is only a pressure which is seen by the ventilator. This is energy delivered by the ventilator to make the flow going in. But in the lungs, the pressure is only the sum of the starting pressure plus the elastic pressure. And this is very, very relevant for clinical practice, because this is the pressure which matters in terms of, in terms of risk of ventilation, ventilator-induced lung injury, but also in terms of hemodynamic effects, for instance. Okay? So you see this resistive pressure is related to the resistance of the airway. And you remember, it's also related to the flow, right? It's flow times resistance. So the higher the flow, the higher will be this difference between peak and plateau, okay? This is volume control. If we were using pressure control, how would be the flow? Sorry? Variable. Okay, this is very, very, okay. Yeah, decelerating, right? So at the end of insufflation, the flow in pressure control is usually very low, right? It's decelerating, or even could be zero. So if the flow is very small at the end of insufflation, the difference between the peak and the plateau at the end of insufflation is very small, okay? So that's why usually for the same volume and the same plateau, the peak pressure during pressure control is lower than during volume control because the shape of the flow is different. For the patient, it does not make any difference because the pressure in the alveoli will be the same, okay? But you will see a difference in the airway pressure. Is that clear? So if you think of the alveolar pressure during insufflation, it's always below the airway pressure, right? Because the flow is going into that direction. So you always have resistive pressure at the airway opening on top of the pressure which will stay in the alveoli. This is the opposite during expiration. Because during expiration, now the flow goes in the opposite direction, right? From the alveoli to the airway opening, to the ventilator. So during expiration, the alveolar pressure is always below, is always above the airway pressure, okay? When do you think that the alveolar pressure and the airway pressure are the same? Even in the back, you can answer. And expiration, so this is not the full response. What explains the difference between alveolar pressure and airway pressure? It's flow. Okay, so to have the same pressure at the airway opening and in the alveoli, you need zero flow. Either because it's the end of expiration, either because you do a hold, okay? When you do a hold, if the airways are open, which is not always true, but most of the time it's true, if the airways are open, zero flow means the airway pressure and the alveolar pressure are the same. Okay. So this is the kind of tracings you can, so this is something you may want to read for your CME credit about respiratory mechanics. So this is the kind of tracings during true mechanical ventilation. You see the flow, the airway pressure. You see a long and inspiratory pause. So here you see very well the plateau. To measure the plateau pressure during mechanical ventilation, you don't need to do a long pause. A very short pause is usually sufficient. So the pause you add at every breath, for instance, 0.2, 0.3 seconds, it already gives you what is probably the peak alveolar pressure, okay? So you don't need to make a maneuver to do a long pause and wait, especially because if you do a long pause and see the pressure going down, it's usually because you have a leak. So just make it simple. Very short pause, you can make it at every breath and you will have the plateau pressure. Of course, there is a limitation to this measurement. One limitation is that the lung is in the chest. And when you measure the alveolar pressure through the airway pressure measurements. You measure the pressure here, which is distending the lung plus expanding the chest wall, right? In general, we think that the pressure expanding the chest wall is not that much. That most of the airway pressure, alveolar pressure you see, is distending the lung. But to be sure that it's true, you need to measure something which represents the pleural pressure, and the tool which is available in clinical practice is the esophageal pressure. So you need an esophageal catheter. We will have a workshop tomorrow to demonstrate how you do it. It's really not that complicated. And this measurement of esophageal pressure, there are some tricks to know, but it's a very reliable measurement of the intrathoracic pressure surrounding the lungs. And this is what you get when you have the esophageal pressure. You have the airway pressure at each insufflation, and then this is the esophageal pressure swings when the patient is completely passive, okay? The patient has no spontaneous breathing activity. And maybe if you have a look, you see the same pressure scale. Well, you see that the amplitude of the swing in esophageal pressure is much smaller than the amplitude in the airway, because this is only generated by the chest wall stiffness or elastance, if you wish, okay? So, well, maybe you would say approximately 2/3 of the pressure, of the airway pressure, are generated by the lung, and 1/3 is generated by the chest wall. So what really matters, if I want to have a very precise setting, is the pressure distending the lung, and that's what we call the transpulmonary pressure. It's abbreviated as P lung, so PL, because this is exactly the pressure distending the lung, okay? Is that clear? Any question about that? And this is just an example showing the elastance of the respiratory system. So when we say respiratory system, we refer to airway pressure. When we say the lung, we refer to airway minus esophagus. And when we say chest wall, we refer to esophagus, esophageal pressure, okay? So this is a series of patients where you have the elastance. So you remember elastance? Is it pressure over volume or volume over pressure?
Pressure.
Wow, fantastic. So elastance is a little bit like the driving pressure, right? It's the pressure you see divided by the volume you give. So these are patients with elastance. So this is patient with ARDS elastance around 25 centimeters of water per liter. Okay, so it would mean if you give half a liter, the pressure would be 12.5. Okay. And what is shown here is that in this group of patients, maybe 80% of the elastance of the respiratory system is due to the lung. So the chest wall is only contributing to a very small part. So if we monitor the plateau pressure, the alveolar pressure, we have a good idea of what's distending the lung. But this is another group of patients who mostly have abdominal issues. So a large part of the airway pressure is in fact related to abdominal distension. And the abdomen is part of what we call the chest wall, right? So you see that for approximately the same elastance, maybe 40, close to 50% of the total pressure is due to the chest wall. which is interesting to know, because then you could say, well, in terms of the risk of ventilation, I could accept higher pressure because it's not distending the lung. Part of it is just trying to push the chest wall away. So this is one of the reasons why we think esophageal pressure can be useful in clinical practice. Okay. When you have these values, you can make calculations. We are not going to spend a long time, but it's good to have an idea of the numbers. So the resistance, you remember, it's pressure divided by flow. So if you take your resistive pressure, you remember it's peak minus plateau, right? It's a drop you see at every pause. You divide by the flow expressed in liter per second. So for instance, you have a peak of 20, 25, you have a plateau of 15, and you have a flow of 1 liter per second. It gives you a value of 10 centimeters of water per liter per second. Okay, we'll see that tomorrow in the workshops. But just to say, if you use a flow of 1 liter per second, you expect a normal value to be around 10. You expect a drop around 10. If the drop is much larger, you may say, well, resistance are high. So maybe this patient has COPD or asthma, or maybe the tube is too small, because it could be the tube. Okay. The only trick is that the flow on ventilators is expressed. Did you see a peak flow? Did you set peak flow on a ventilator? I'm sure some of you did. How much do you set? 60 what? 60 liters per minute, which is very confusing because liter per minute, it's for usually what we use for minute ventilation, right? But here we are talking of continuous flow. 60 liters per minute would mean that if you insufflate for 1 minute, you will insufflate 60 liters. To me, it doesn't make sense. I'm interested to know what's the flow for my insufflation time. So if you express the flow not in liter per minute, but in liter per second, so 60 is 1 liter per second. Okay. So this is how you have to calculate resistance. And the other calculation is elastance or compliance, and we'll talk a little bit more often about compliance. You will understand why. So compliance is volume divided by the elastic pressure. The elastic pressure is the plateau minus the PEEP or the PEEP dot, as you will see. You may see that in patients with normal pulmonary function, normal compliance would be 100 milliliter per centimeters of water. I would say we never see that in the ICU. Normal compliance for patients with lying down on the bed, and most patients have some degree of atelectasis, is around 50 ml per centimeter of water. You would say, well, for an adult, that's maybe about normal. Okay. Yeah, we talked about resistance already. So resistance is it's really the pressure drop within a tube or a conduit, and the calculation of resistance, it's really a calculation. It's not a direct measurement. You divide this pressure drop by the flow. And when you do that, you may be surprised, because if you change the flow, you expect to change the resistive pressure, but you may think that the ratio, so the resistance calculated, would be the same. It's not true. Usually there is a this kind of relationship. And the reason is that when you increase the flow, usually you change the type of flow. You may remember the laminar flow, the turbulent flow. So if you increase flow within a given tube with a given diameter, you will go from a laminar flow to turbulent flow, which needs much more energy or much more pressure dissipation. So in terms of calculated resistance, the pressure, the value will go up, okay? So it's important to know because this is the case for every endotracheal tube. It's non-linear, or usually in the upper airway, okay? And this is why when you have a, narrowing of the airway, you may go very rapidly into respiratory distress. You have turbulent flow. So this is just the schema of what I say. When you have insufflation, the flow is going from the vent to the alveoli, and during the inspiratory time, the pressure at the airway opening is higher than the alveolar pressure. During expiration, it's the opposite. The pressure in the alveoli is higher than the pressure you read on the ventilator. And the only time when the pressure are equal is when you have zero flow. Okay? So this is an example of tracing. You have the volume, you have the pressure, and you have the flow. Do you recognize which mode of ventilation it is? There is a trick. So it is volume control, but the trick is that they put the flow in the opposite of what is usually displayed on the vent. So on the vent, usually inspiration is positive and expiration is negative. Again, this has no physical meaning, positive or negative. It's just a direction, right? So if you reverse your sensor, instead of having a positive flow, you will have negative flow. So this is the insufflation, and you have a square flow. Okay? I think they put the expiration positive because they want to show here something happening during expiration. A normal expiration, in terms of flow or in terms of volume, is an exponential curve. Okay, we'll see that in a moment. There is something special they want to show here on this expiratory flow curve. What is it? Right. At the end of expiration, so this is the next insufflation, there is still some expiratory flow. So the lung is still inflated, right? This is the airway pressure. You remember the pressure at the airway opening? This is the pressure you see on the vent. Because there is flow, what can you conclude about this pressure? You remember we said during expiration, the pressure in the alveoli is always higher than the airway pressure, except when flow is zero. Flow is not zero. Exactly. So you don't know exactly what's the pressure inside, but because there is flow, there must be a pressure gradient. So there must be an upstream pressure in the alveoli, which is higher than the airway pressure. So this patient has intrinsic PEEP, okay, auto PEEP. You don't know how much, but you're sure it is. And the reason is that there is not enough time for this patient to exhale completely. So what does it mean? It means that in a system where you have resistance and compliance, the expiration, so this is the volume going up to V0, the expiration has an exponential decay. Every normal expiratory curve, either flow or volume, it should have an exponential decay. If you see something different, it means that it's not a normal expiration, either because the patient is breathing or because there is some kind of obstruction we will discuss, okay? But usually it's like that, and the equation is characterized by the time constant of the system. And the time constant, it's very simple to remember, it's just the product of resistance time compliance. So you remember resistance is pressure divided by flow, which is liter per second. And compliance is volume divided by pressure. So pressure divided by flow by time. At the end, when you do resistance time compliance, you have seconds. Okay? So for instance, a resistance of 10 centimeters of water per liter per second times the compliance of, let's say, 100 milliliter per centimeters of water, it's a time constant of 1 second. And in such a system, you need 3 or 4 time constants to expire everything. Okay? So the example I showed you, you would need 3 seconds to expire normally. So in any patient, it's very simple to create autopip just by shortening the expiratory time. Okay? And well, this is just to show tracings in patients with ARDS. ARDS, what do you think? Do you think they have long expiratory time, or do you think they have long time constant or short time constant? Why do they have short time constant? They are very low compliance, so the time constant is usually short. Who are the patients with long time constant? COPD, right? High resistance, high compliance, you have very long time constant, okay? And these are ARDS, so you may recognize volume control with a square flow, pressure control with a decelerating flow. You see the peak pressure is lower despite the same plateau. And this is pressure control with inverse ratio ventilation. So you see the insufflation has been prolonged. Everybody see that clearly? Okay, so because the insufflation has been prolonged, the expiration has been shortened, right? And you see that the expiratory flow is interrupted between the end. So it was just to show that even in ARDS with short time constant, if you reduce the expiratory time, you will generate intrinsic PEEP and autoPEEP. Okay? And the first reports about this mode of ventilation, pressure control inverse ratio ventilation, people were saying, well, it's fantastic because the oxygenation goes up. And the reason was simply that they were generating autoPEEP. And when studies compared to the same PEEP level, they did not find any difference, okay? The difficulty in clinical practice is that there is a second frequent phenomenon explaining autoPEEP. So not only time constant, but something called flow limitation, which honestly, we don't completely understand, but we think it's due to the small airways which collapse when the pressure surrounding these airways become higher than the pressure inside the small airways. So it's very frequent in COPD. Maybe 80% of COPD under mechanical ventilation have flow limitation. But we have realized that it's also frequent in ARDS. Maybe it's simply because the lung is so heavy, so it compresses the small airway. So in this case, what you see on the flow tracing is like that. Instead of a nice expiratory curve, you see a kind of abrupt deceleration. And then you have a very small flow, which takes very long for complete expiration. So this is a problem in clinical practice if you want to remove intrinsic PEEP, because simply prolonging expiration will not be very efficient. It will help, but not very efficient. For time constant, it's perfect. You just adjust the time. For this is more of a problem. So this is a nice example. So you see the peak airway pressure, the flow. What do you notice on the flow? So two things. What do you see on the flow shape? It's interrupted here, right? So this is a sign of intrinsic PEEP, and it's not an exponential decay, right? So this is typical of flow limitation, of severe flow limitation. So we see that the airway pressure is 0, but we don't know what's the real alveolar pressure. Okay, so I guess you all know what to do to know the alveolar pressure. What should we do to measure the alveolar pressure? No, before esophageal balloon. Yeah, just an N expiratory hold or pause, right? Which will interrupt the flow. So with 0 flow, you will have the alveolar pressure. Okay? And this patient had 15 centimeters of water of auto-PEEP. You cannot see it. Okay? So this patient was in shock, and the only reason was because of intrinsic PEEP. This is one of the main concerns with auto-PEEP, is the hemodynamic effects. Okay? In patients with flow limitations, in general, if you add external PEEP, let me say it in a simple way, you don't do anything on the value of auto-PEEP. So the way it has been illustrated is the waterfall analogy, which would be that this would be your auto-PEEP. This is the external PEEP. You can increase the external PEEP from 0 to 10. You will not change its value. Okay? Only if you go above, you will increase the total PEEP. So this is not exactly the same thing when you have just a matter of time constant. And therefore, it may be mixed. There may be some patients where you increase the PEEPs, some patients where you do not, okay? But in general, if it's flow limitation, you do not do anything on the alveolar pressure by itself. Do you understand? So do you think that in a patient with the preceding patient I showed you, intrinsic PEEP of 15 or auto PEEP of 15, if I add external PEEP, is it going to help my patient?
Yes.
Yeah. A bit louder. So
You're helping because you can detect it, but you're not helping the patient in the sense that you're still stuck with that pressure.
yeah, there was somebody in the back commenting. Yeah, sorry.
As I understand, this is the theory behind using high PEEPs in asthma, is that by increasing the peak, you're now allowing flow to occur. So therefore, expiration.
The problem is that, yes, you will allow flow to occur, but only when you are at the level of the choking point or the closing pressure. So,
Your attention, please. Code blue.
so in terms of decreasing hyperinflation, it does not help.
Room 130.
Okay?
Code blue.
So why do we use external PEEP? Because it decreases the pressure gradient, and when the patient is breathing spontaneously, well, it helps a lot the patient. Because to make flow, it's just a small drop in pressure instead of a big drop in pressure. So it's very useful for spontaneously breathing patient, but for reducing hyperinflation, does not help. Okay? So it's not, usually we think, oh, intrinsic PEEP, we should add external PEEP. That's not the point. So what should we do in this patient? If you want to help this patient.
You can do other measures like increasing the expected flow, extended expected time.
Yeah, that's what we say. We can try to prolong the expiratory time, but again, it will not be very efficient. Anything else we can do? Sorry? Why? Nothing magic, huh? Still the equation of motion will be the same, huh?
You may improve the flow rates.
Yeah, you may give bronchodilators for sure to try to decrease resistance. Yeah. The most important in that case is to decrease the amount of ventilation going in. Okay? So if it's time constant, it's really about the settings and your time. If it's flow limitation, it's about giving less volume. Okay? So maybe accepting more, a higher CO2. Okay, let's finish with compliance and then we'll move on. Because there is something very important to understand about compliance. So compliance is volume divided by the elastic pressure, which is plateau minus PEEP, and elastance is the opposite. And again, you can use one or the other. So, as I told you, a normal compliance in an adult patient in the ICU would be around 50 milliliter per centimeters of water. Again, it's not a normal value in the PFT lab, but it's something we see often. So it means that if I give a tidal volume of 500 ml to my patient, I give no PEEP, what will be the plateau pressure? The plateau pressure will be 10, so that 500 divided by 10 is 50, right? Okay, let's take the same patient, but now intubated selectively only on one lung. I know it doesn't happen in your ICUs, but imagine. So the patient is receiving the same tidal volume, but only in one lung. What do you think will be the plateau pressure? 20? Who said that? Very brave. Well, in the same lung, instead of delivering 500 divided by 2, let's say if the two lungs are equal, you give the 500 in one lung. So the pressure will be higher. And let's say if the compliance is linear, yes, it will be 20. Well done. So what's your new compliance? Your new compliance, sorry, is 25. So nothing has changed for this patient. This patient has not developed acute fibrosis or pulmonary edema. Maybe he will, but it's simply because you have less volume available, your calculated compliance looks smaller. So this is very important to remember because compliance is mostly an assessment of the lung volume available. Okay? Who are the patients with the smallest compliance in the ICU? Baby lung? What do you mean baby lung? Arts with baby lung? Neonates. The smaller you are, your height, the smaller is your compliance, okay? They have compliance of 0.1 ml per centimeter of water, something like that. So just remember that because this is one of the reasons why we are interested by compliance. So this is your baby line, right? So the way I remember, if we say you have a patient who have a compliance of 100 ml per centimeter of water, let's say it's the equivalent of having 100 units, each one having a compliance of 1 ml per centimeter of water. So the total compliance is the sum of that. So if you now have a severe pneumonia and you have, like in the RDS baby lung, you have only 30 units left, your compliance will be 30, okay? So this is one of the reasons why we often speak of compliance more than elastance, because the calculation is not the same. Okay, and I will go again on that again, but this is the reasoning behind the driving pressure. Compliance is proportional to the lung volume. It's volume divided by the elastic pressure, which is the driving pressure, plateau minus PEEP. So the driving pressure, which is very easy to measure on the ventilator, is your tidal volume related to compliance, which is an assessment of the lung volume. So instead of expressing tidal volume in milliliters per kilogram of predicted body weight, which is a kind of predicted size of the lung, it's more the actual size of the lung. And this is why we have this data, I'm sure you're aware of that, saying that driving pressure under mechanical ventilation is a very, very strong predictor of mortality. Oh, so now I have two questions for you. So I tell you the question, then you log in and I will give you the code. So a patient sedated in volume controlled ventilation experiences a sudden series of alarm on the ventilator related to high peak pressure abruptly increasing. So the alarm is temporarily increased, the upper alarm, and the plateau pressure is re-measured. So it seems to be stable compared to previous measurements. Okay? High peak pressure alarm, that same plateau. Do you think this can be caused by a pneumothorax, a sudden atelectasis, pulmonary edema, cuff leak, or secretions? Okay. So where should I go? Oops.
Just hit Alt Tab. Yeah, there you go.
Oh, so you have to vote. So you have to log in. This will be always the same login. And you have to use this code. And don't be influenced by the first response, right?
Testing, 1, 2, 3. Testing, 1, 2, 3.
Seems to be blocked with only one response. Okay, I have voted. So if I can vote, I'm sure you can all vote. So you and how long do we wait?
You stop whenever you want.
Okay. So 57 people, 58 people, 59. Okay, one more. Okay, so 59 people in the room have given the correct answer. Only 3 people, I know 2 of them. I've showed the, so show correct answer doesn't work.
That's it.
Okay, good. So it's obvious it's because we have increase in peak pressure, no change in plateau pressure. So no change in the elastic property, which would be the case with pneumothorax, with atelectasis, or with pulmonary edema. And of course, we have no leak because the pressure is going up. So it must be something in the airway resistance. So it should be secretions. Okay, and I have a second one. The code is still the same. Yeah. So we did not discuss that, but that's okay to discuss. The patient is ventilated with 6 ml per kilogram tidal volume, a PEEP of 8. The plateau is 23. The PaO2 is 80. The PCO2 is 45. Systolic arterial pressure is 100. The PEEP is now increased to 15, so it's a PEEP test. The plateau is 30. The PaO2 is 92, the PCO2 49, the systolic arterial pressure is 89. So there is an increase in oxygenation, but you think the patient, 1, may have relative hypovolemia, 2, may be over-distended, 3, the patient benefited from PEEP, 4, a higher PEEP might be tested, and 5, FiO2 can be decreased.
Go to present in the top corner. And then, yeah.
Okay. Oh, this is my fault because you can give only one response, one good response, right? I would say there is 2 possible responses. Okay, great. So I would say the first 2 responses are correct because what we have seen is an increase in PCO2. So this is not something we discussed today. We will discuss later. An increase in PCO2 for the same minute ventilation means what? Means either a higher CO2 production, for instance, cardiac output is going up. This is unlikely. Or it means higher dead space. Okay? Higher dead space may be generated by distending alveoli, which block the circulation. So when you see PCO2 going up, this may be a sign of increased dead space. So these patients may be over-distended. I think this is a very good response. The patient may also be hypovolemic because of course this increase in dead space will happen more rapidly if the blood pressure is low. And also we saw that the blood pressure went down. So that's also a reason why the patient may be hypovolemic. So I just put this question to say, you have to take the measurements we have discussed into the global context of the patient, okay? You cannot use one measurement like driving pressure plateau and say this is everything about the patient. You have to put everything in the context. And in this patient, we saw that the driving pressure did not change. The plateau was what was expected. So maybe it was good for the patient, but the oxygenation increase was very small. And this may be because the patient was hypovolemic. So this is how you should apply it at the bedside. Okay, I stop there. Any further questions, or maybe we move on? Yes?
Just come from Australia. We use a lot of autoflow
Okay.
in our machines. Do you, in measuring your plateaus and peaks, should we switch that off?
So autoflow means there is an automatic adaptation of the pressure level. Well, that's really a very complicated situation to measure mechanics because you don't have a constant flow. And second, you change the pressure all the time to adapt to mechanics. So I would say to measure mechanics, volume control square flow is really the simplest. It really helps.